Good evening, everyone. Good morning, everyone. Welcome back to another episode of Dhammapariyesana. Today is day 30. Dhammapariyesana series does not only focus on the Buddhist matters, it is also, uh, you know, very focused on other issues, especially cultural issues, as well as other uh, important events and other important issues at hand that we can see in society. So, in today's discussion, we will be looking at how important it is to have a culturally competent cancer care with some Buddhist insights, because we know when there is a culturally competent cancer care, this is such a very beneficial thing for patients who are going through different stages of cancer. And I also think that this is not only a thing that is especially focused on cancer patients. This is kind of a widespread concept that everyone who is going through medical issues, they should be given this cultural competent care. And I also think that this is not only a medical concept. This is also a concept that uh, we can see and we can bring into other societal activities, like when you are doing a service, when you are giving a service to other people, customers, clients. We can see that there are many groups of people involved in many services. So if we could bring this cultural competency, which means the people who are giving the service, they understand the cultural sensitivity and the norms, societal norms, and everything related to that, they can give a better service. And people are not dissatisfied. People feel happy. People have a better interaction with the service professional and the client, the customers, people, in this case, patients, cancer patients. So if I put cultural competency in a medical perspective, it is basically an effective and appropriate communication with people of other cultures. This is basically what cultural competency means. So today I invited a special guest to talk about this thing, and I'm particularly interviewing her. It is a great pleasure for me to introduce our guest today, Sarani Fernando. She's joining with us from Vancouver. Sarani has a Master's of Public Health. Uh, I guess it is from University of Alberta,
That's right. Yeah.
and she works at the Center for Health Evaluation and Outcome Sciences, which is called in acronym CHAOS, which is not the chaos but chaos, which is also a part of UBC, University of British Columbia. She currently manages several projects while conducting qualitative research in a variety of healthcare contexts. Her recent work focuses on cultural competency, which is a subject that we draw out some highlights today, as well as youth mental health and the overdose crisis in BC, which is a big problem in Western Canada. People are dying from what we call uh, fentanyl and other drugs. So it's a big problem. Not even in Western Canada, but also in other places. But we can see there is a crisis in that part of the country. She is also an artist who has been drawing and painting for most of her life. I hope that we could ask some questions about that too if we have time. In 2014, she discovered her love of watercoloring and has since made numerous commissions with some raising money for various non-profit organizations supporting vulnerable persons and animals. And I know Sarani has been going through a painful time. On January 20th this year, her father passed away. His name is Kirti Fernando, who was a very staunch, good Buddhist, good person, gentleman, who I know for some time because I spent some time in Vancouver for around 5 to 6 years. And I think that she's being bouncing back and kind of resilient about what's going on, and she took some time. But I know that she's very vocal about how she saw cancer with a family member, and how she uh, saw cultural competency when she brought her father to medical care uh, in some hospital facilities, and she saw that on her own eyes, and I think she has a lot of things to share with us today. So let me get into the topic this way. Sarani, thank you for joining with us today.
Thank
How are
you.
you doing today?
Good, and thanks for having me on this platform. I really, really appreciate it, and for the
Okay.
time that you have with me today.
All right. So we understand that cultural competency is such an important aspect of medical care, not even in cancer care. So, but we have some issues as well. Now, how do we locate culture? Because if you take a country like Canada, which has a multiculturalism, we understand that there are different types of ethnic groups in even in one set up of group. Let's say there are first generation immigrants, as well as it can range from first generation to sixth generation, like people like you. So how do we sort of understand who is our focus in these groups? So if we also get into other differences within one culture, let's say, uh, you know, things like generation, level of ration, citizenship or refugee status, circumstances of immigration, and the preparation of his or her life spent in this country or in other countries. And there are so much to deal with in understanding this particular group that we're going to address by with cultural competency. So it's kind of almost impossible to know everything about every culture. So when that is at hand, how do we sort of specify the kind of group that we are addressing with this topic? This is one area of this subject about cultural competency. And on the other hand, I understand that there are ethnic groups of people who might not be assimilated into the mainstream culture. They have some prejudice. Some of them, they have some prejudices that the doctor that is not in my ethnicity will not take care of my needs. So it's kind of a prejudice that you know those kind of people might have. So but the doctors and medical professionals are not like that. They are really good. They want to take care of them, but these people don't understand that. So this is another side. So all in all, when we have these situations, how do we understand the sort of people that the medical professionals in this case should address with cultural competency? So how would you see this cultural competency with these issues? The first issue is, how do we locate, specify the kind of people, and at the same time, we might sometimes miss out on this important perspective about prejudices from the patient's perspective as well. So how do we look at these two, Sarani?
There's a lot to unpack there, and that's a really, really important question. Especially when you look at intergenerational differences and assimilation and acculturation and things like that. It's very multi-dimensional, and I think, let's start with who to address and how do we define who to address. It's mostly within the healthcare context, just because we're focusing on healthcare, is looking at disparities and healthcare disparities, and that's kind of an indicator of the barriers that might be present with certain cultures. And it could also be within certain generations or a particular gender within a culture as well. So those are a few nuances around that. But overall, we kind of look at healthcare inequities as well as disparities in accessing treatment and care, as well as adequate and optimal healthcare outcomes associated with that. So from a data standpoint, we kind of look and see, what are the outcomes of different ethnic groups, and based on that, where are we seeing some disparities and differences, and where are we seeing some barriers. And I mean, I know that you have a global audience, and I come with a Canadian healthcare lens, but just anecdotally here in Canada, we do a lot of work around Indigenous health. So that's an example of where we see some very clear inequities with one cultural group versus another predominant cultural group, and very different modalities of medicine as well. And in addressing that and seeing the disparities and different health outcomes with certain diseases, we have to target that by looking at the cultural dimensions as well as other elements in place. So I know that with this conversation, and just based on my background, we're going to look at the South Asian population, and a couple of qualifiers here. Well, let me backtrack a little bit. So a few of the projects that I've been working on coincidentally kind of lined up with this journey that I had with my dad when he was diagnosed with stage 3 colon cancer. I had 2 projects around, South Asian patients and their barriers to care, but it had nothing to do with cancer. It was one related to live donor kidney transplants, and the other was related to type 2 diabetes. And I kind of drew parallels from those projects to my dad's experience with cancer care. And I noticed that there was one cohesive thread, and those were, cultural, I would say, dimensions and cultural barriers to optimal health. And we can go into that into detail later. But a couple of those things were, different gender norms, perceptions around, power hierarchies and power structures within the healthcare system. Also, food is a big element of South Asian culture, especially when you're talking about kidney disease and diabetes, things like that. So I don't know if that answered your question, but there's so many different ways to qualify an ethnic group or culture. Usually it's tradition or language. Language barriers are another huge issue here, as well. Just gender norms and intergenerational norms and level of acculturation. Usually we see it with a bit of the older generation, so my parents' generation, the baby boomer generation. So yeah, there's a lot of those things to consider.
Yeah, that's a good introduction. At the same time, I want to ask you, what is cultural competence to you, in short?
Cultural competence, so there's a lot of different definitions of what it is in the context of healthcare. It kind of starts with understanding your own culture, because it's a reference point. So how do you define your own culture? And it could be very personal. It could be a blend of cultures. For me, it's definitely the case. It's a blend of 2 different cultures. It's also understanding cultural diversity, and it's also appreciating cultural differences. The other elements to cultural competence is increasing your awareness and knowledge to other cultures, and being open-minded to other cultures. And finally, another element is adapting to other cultures and revising practices to accommodate other cultures to help optimize their healthcare and also reduce disparities in healthcare.
Okay, sounds good. And now we're going to talk about, let's talk about a little bit about an effective, cultural competency in healthcare, with an emphasis of cancer care. Now, we know every field is not excluded from some of the bad prejudices and biases. Like I would say, prejudices related to stereotyping, racism, classism, sexism, homophobia, right? And there are many more to talk about, I mean, if you're going to talk about. So the thing is that with cultural competency, I think there is a better connection in the medical settings, be that in cancer care or other place. So, what do you think? What the medical professionals in this case can have as attitudes, at the same time steps that they could develop in terms of cultural competency? Because I understand this is where we're going to talk about Buddhism,
Yes.
because it's not just a medical professional, especially oncologists. They just get to learn something, they're just going to deliver as a job. So this is where they're going to look at how effectively, how efficiently we can, bring the patient to the treatment. As you delineated about the food issue, language barrier, I think, some of the other related issues as well, they all kind of, combine all that. So how do you think that medical professionals can have better attitudes about cultural competency, as well as what are the steps that they can put into practice? And number folks, please don't misunderstand that the medical professionals are very new to this. Uh, uh, they've been learning this for some time now, but we are trying to give some insights about this specific context, because there could be some places where we don't feel that these specific cultural people getting the efficient, effective treatments, especially those services. That's why we are trying to digging into this concept. So, Sarani, could you share with us about uh, you know some attitudes and steps that the medical professionals can take in terms of an effective cultural competency in healthcare, maybe with an
Yeah.
emphasis about
Yeah.
cancer care?
I think I think kind of unpacking that a bit and talking about attitudes first before we talk about the steps taken is really important in this case, because you do really need to shift an attitude towards something called cultural humility. And the term cultural humility essentially means, being aware of your own biases towards other cultures, understanding, what prejudices you might have, whether it's subconscious or whether it's something that you overtly express, and also just being aware that one culture is not better than the other, and embracing other different perspectives and respecting other people's beliefs, and not saying, well, my viewpoint is more superior than your viewpoint. There might be a reason why they have that viewpoint in the first place. So kind of appreciating where those views come from, and understanding that we have diverse perspectives around us, and diverse cultures is kind of a humble practice, right? So it's kind of grounding yourself and making sure that you don't think you're superior, because that kind of alters when you place someone like that in the healthcare practice. It determines the way they conduct their practice. So I think the attitude shift is very important, and cultural humility is important. And some steps, these are broad concepts, but how do you tangibly apply this into a healthcare setting? So that's one of the most important questions that you asked. And what are the logistics? How do we actually do this in real life? It's not, a one bullet type of thing that will address something as complex as culture. You can't expect to have one answer to a multi-dimensional issue such as culture, right? So in this case, you could kind of target it in different ways. You can have a community champion involved. You can have community liaisons involved, and I'm speaking, in terms of the healthcare context, inviting them onto the team, having cultural trainings for healthcare professionals. You see this a lot with Indigenous healthcare. Sometimes it's mandated in certain healthcare contexts to take those courses and to understand that culture. There's also, resources and other materials that you could introduce people to, whether it's books or literature. There's also seminars. So there's so many different ways. And mechanisms that you can address this issue, either by raising awareness or actually actively going into the community and recruiting people onto your team. Having more minority groups on a healthcare team, having a diverse group as opposed to just one cultural group representing a care team is important as well. So yeah, there are many different ways that you can address this.
Okay. Sarani, we wanted to sort of understand the kind of group of people who we talk about here, and this involves physicians, psychologists, family medicine doctors, GPs, pediatricians, and there are many more. And what I understand from you is that you know they have to make some good policies, publications, especially the medical societies. There are many societies of physicians, psychologists, and etc., etc. They had to review the new situations about the nexus connection between patients and medical professionals, and they have to update what and how they can do this better. And if I sort of summarize what you said, because we need to break down these barriers, these stereotypes. Uh, what I understand is that there should be an awareness on the side of these medical professionals about this issue. They have to be aware. At the same time, it is their responsibility, kind of a responsibility, to accept these cultural aspects. At the same time, willing to help. Uh, Also, recognition, as you said, the cultural humility and respect, especially when it comes to these kind of patients. They don't understand sometimes what they say. They need some interpreters, they need some translators. They have some issues, like you said, about the food, right? So I mean, they can enhance those attitudes. When it comes to steps that they could take, I mean, the whole medical industry is that they could sort of increase interpreter services for these patients,
Mm-hmm.
as you said, and recruit some minority staff, so that they will be more comfortable, right? When that kind of a person gets to reach hospital, and they will be comfortable. And these are people that I know I'm comfortable with. At the same time, incorporate cultural specific attitudes, as you said, values into health promotion tools. And finally, the most important thing is to uh, increase facilities about linguistic competency, because this is the biggest issue that they are having, right? Because they wanted to express themselves, right? And my understanding is that we are not trying to say that this particular ethnic patient should only see the particular ethnic doctor. What we are trying to understand and share with all of us is that we, the whole industry should be able to coin a concept that we should be able to feel this sensitivity uh, from all these patients. We should be culturally sensitive. It could be a different ethnicity, but we should be able to make this connection in the clinical settings. Okay, so that's a big question in
Yeah.
today's time, right, Sarani? And okay, this is kind of related to our main idea behind Buddhism. So, how do you blend cultural competency with Buddhism? Because people might be uh, kind of like excited about knowing this thing in particular, because we understand there are a lot of things to discuss. Now, one important thing is respect and tolerance. So we are mutually, respectful, between these two categories, patients and doctors, medical professionals. At the same time, tolerance, and the word patient is also something which was coined by this tolerance, and compassion and wisdom. This is a bigger concept, because we need to be compassionate. Awareness, because if medical professionals are not aware, at the same time, if the patients are not aware what's going on, they also will be in a very dissatisfied mood. Equality, at the same time equity, and all these concepts, they are related to the Buddhist ideals about cultural competence. So how would you say the interconnection between cultural competency and Buddhism in your own way? You don't need to talk about like a lot of bigger, sutta readings, but you could share with us about that.
Yeah, I'm definitely not an expert here, but I know, so there's two parts to this. I think I approached this thinking about, how Buddhism can be instilled into healthcare to make it more culturally competent, just to help understand things like end of care, palliative care, because there's a lot of things obviously that are happening at the end of life that people have questions about, whether it's the afterlife, whether it's, why am I going through this much pain? Why, answers to why there's suffering and things like that. And I think the missing piece there, especially in terms of we're talking about cultural competence, is people with those backgrounds and frameworks and who gravitate towards that type of spirituality may not be able to grasp some of the things that are happening, especially when they're in a completely different context where they're being told things in a certain way. They may not be able to grasp that without having a framework that makes sense to them. So I think I kind of I came in with an understanding that religion is one big marker of culture, right? And why is there just one dominant religion infused into the way that healthcare is delivered, when there should be a broader understanding and different understandings of very important concepts like death and suffering, right? So that was one piece. The second piece is through a Buddhist lens, how can we be better Buddhists? Like why is practicing cultural competence important through the lens of Buddhism, essentially? And that's something that I'm not really familiar with, but all I can say on that is the reason why this is an important thing to talk about is it affects healthcare outcomes, right? And I kind of frame that in terms of you have to take the right actions, right? And you have to take the right effort and do the work to address the problem, as in why we see health disparities and why we see poor health outcomes in certain cultural groups as opposed to other cultural groups. So how can we use the Buddhist lens and the practices of Buddhism to fulfill that goal? And I've noticed just from my experience philosophically is just increasing your awareness and understanding, being humble, and putting the right effort in the right place can actually help promote the health of people who are at a disadvantage.
Sarani, have you heard about something that, I discussed this with somebody in a previous discussion. People like to be spiritual more than religious in today's world.
Yes.
Kind of looking at spirituality as a stepping stone, in their life. So like mindfulness, compassion, they've been topics which look to have no affiliations at this point, although we learn specific classical ancient teachings from different religions, and we know Buddhism is neither religion nor philosophy. But have you, this is kind of something different than this perspective, have you also heard that there are some religious traditions that we don't try to name them or kind of like name their sort of treatments, but there are people, because of the pressure that come from religious perspectives, they are not thinking to get treatments like vaccination, sometimes other things too. So how would you address this? I mean, do you think this is something that somebody kind of like, misusing a concept like cultural competence, or is it something that the modern medical professionals should allow? But there are other issues too, in case they come up with a different plan. Why you did not help us do this treatment? It was your responsibility, but you didn't do that. So there are some suing issues, lawsuits that could, come after the problem. So how would you concern about this spirituality? Because we know that people like to be spiritual more than to be religious, and it's true. And Buddhism is you know uh, lying at a place between religion and spirituality. On the other hand, what do you think about the people who are pushing their religion, uh, you know, towards this medical profession, so that they are in a position that they can do their thing, and there are other things involved with too. So how do you see these two?
Yeah, that's actually a really excellent question, and that actually kind of gets into the realm of bioethics, and it's a very important thing, and it's very related to this issue, like you mentioned, of cultural competency, because people can come in with dangerous attitudes, and brand it as their culture. And I think from a healthcare perspective, which is the one that the lens that I come with. Um, Without going into too much detail, you almost have to balance harms and risks, right? There are concepts around autonomy and concepts around something called beneficence. And whether you want to do, more harm to the greater good versus harm to the individual, and balancing risks and benefits, and saying, okay, well, if you want to do everything you want to do as a patient, does this have larger implications to, a larger population? Could it have negative implications for a public health perspective? So it's kind of a fine dance that you have to do in the realm of public health. And decision making is done based on science. And I think the reason why we look at cultural competency, like I mentioned before, is to really target people who are showing, different healthcare outcomes, right? And it's actually done as a tool to improve their health, not to reduce their healthcare outcomes, or not to endanger them, and not to put them at greater risk. It's actually to promote their well-being. So you almost have to take it as a case by case, and see, does this actually work for the patient? Cultural competency should really be in line with something called patient-centered health and patient-centered outcomes. And what that means is tailoring healthcare to a patient. So it's taking broader concepts, but kind of making them work for the patient, right? And then it's important to articulate, if there's, I don't want to talk about other contexts, but if there's greater risk to other populations, if you're talking about infectious disease, for example, there are risks to the larger population, let's say, when we're talking about vaccination, right? So there's implications there. But that's kind of not our area. But, in the context of cancer, that's not really a discussion that is had. But yeah, you do have to balance risks and benefits, and that's something that's constantly happening. And with the pandemic, it's definitely an issue that we talk about all the time.
Because this issue, continuously exists behind people not taking vaccination, COVID vaccination, because of cultural competence. That's why it's a big thing.
Yes.
But anyways,
that's
yeah,
a controversial subject.
yeah, it's a controversial subject. Let's leave it as it is. Okay, suddenly now we have come to a point to discuss about why cultural competence is important to cancer care. Because I know that you've been going through with your father's situation, and you could perhaps add some of your circumstances about how you dealt with looking at the importance of cultural competency. And do you think that your father got this cultural competency from sort of medical professional that he was going through?
Yeah. So just to talk about my dad's case a little bit. So he was diagnosed with stage 3 colon cancer in 2016. And he ended up getting surgery to resect a part of his colon, and then subsequently started 12 rounds of chemo. It was an adjuvant therapy and a baseline therapy that he completed all 12 treatments. And then he actually was in remission for some time. And then big C cancer came. I call it big C cancer. I don't remember where I read it, but there's little C cancer and then there's big C cancer. And he noticed a lot of pain and tingling in the legs in 2019, actually before 2019. But then it got to a point where he realized there's something nefarious going on here. He got some screenings done in 2019, and the cancer had spread to the spine, lymph nodes, and pelvic bone, and surrounding areas. So it was not good, and he was diagnosed with stage 4 at that point, metastatic cancer. He went through more radiation for his cancer, and then he ended up having, some more time with us, but unfortunately passed away actually almost a month ago on January 20th. So we saw him from the beginning of this journey to the very end of the journey. We were able to see his interactions with healthcare at the start, in the middle, and at the very end. And let me just say, it was very different throughout, based on where he was at, because the conversations change based on the person's health and based on what is happening, obviously. So at the beginning, we weren't even thinking about end-of-life care. We were thinking about how to promote survival, how to promote, how to reduce or how to improve quality of life, as well as eliminate the cancer altogether. Whereas near the end, it had nothing to do with promoting survival. It was all about comfort care. How do we come to terms with end of life? How do we come to terms with, the body shutting down and letting go and things like that? So it was a big shift. People often look at cancer as, you have to have the same conversations throughout. It actually changes. It's very dynamic. It's quite an interesting process. So I would say that cultural competency was a huge element. I mean, obviously this is a multifaceted thing, and why the way people interact with healthcare and the way people receive healthcare depends on a multitude of factors and a multitude of intersecting factors, right? It could be their gender, it could be their age, it could be their socioeconomic status, and we're only talking about culture here. But I noticed that with my dad's, and I wish he were here to share his own perspectives, right? This is only coming through my lens and through anecdotes that I heard from my mom and my sister, and through his,
I had a phone conversation with him back in 2019.
Oh, yeah. So there we go. Yeah. So we can also
Sometimes
share.
Ago.
Yeah. So his, we've learned our own through witnessing and through talking with him. He did express certain things that not necessarily he would qualify as cultural issues himself, but maybe it's my researcher brain. And because I was working on these projects, I was delineating between what was personal and what was cultural while we were going through this process, and saying that actually sounds like a cultural barrier. One example, I don't want to spend too much time talking about all the different examples, but I want to focus on the end of life aspect, because that's kind of when all of these discussions are tremendously important, I'd say. because you're talking about things like conceptualizing what happens in, after someone dies, how to embrace, impermanency, or how to embrace that, this body isn't ours and that we're just inhabiting this body in this lifetime. And concepts that, Buddhism really plays into, especially when my father, who is a Buddhist, this is a huge part of his life where these things interplay, these concepts and practices interplay with his understanding of what's going on. So I noticed, because he was in hospital for a big chunk of time, and because of the pandemic, my mom was the only person in the family who could go visit him. So we couldn't really have like a monk or someone just come in and visit him at the hospital to help him understand some of the things that were being told to him. I think some of the issues that he was having was, when a doctor would plainly say, oh, yeah, your cancer is completely, it's spread, you're paralyzed from the waist down, and you only have 3 months probably. And just say it just like that, And I know that's, we could talk about that more, but I think especially with South Asian culture and what I've learned is people more readily talk about physical conditions and the physical issues that happen at the end of life, but they rarely really address one of the most important things, and that's mental health. And the depression and anxiety and fear that happen at the end of life, because it's obviously a scary time. It's a scary time. And theoretically, we know that we're all going to die. And we know that this is all going to happen to us. And I think when it actually gets to that time, there's a lot of fear and anxiety. And if you're put in a healthcare setting where you're not addressing those anxieties, and you don't have a continuity of care while this person is exhibiting signs of anxiety and fear and pain, mental pain, that's a problem. And I'm confident in saying that in his case, cultural barriers were the case here, because a lot of members from the palliative care team, including physicians, palliative care doctors, would talk to him and say very plainly, we want to put you in hospice, and you're ready for hospice, you're ready for palliative care. Those words he wasn't really ready to hear because of these truth-telling concepts that Western medicine embraces. He wasn't really, and I'm not saying one way or the other is bad. I'm just saying that because of his cultural background, those words did not resonate. And I think, talking about death in a different way, talking about end of life in a different way would have been way more beneficial to him. Unfortunately, the pandemic, and, even without the pandemic, I feel like there's a lot of restrictions within the healthcare system in addressing this at this time. Yeah.
I like the things that you brought up in terms of the Buddhist attitude, and he was not able to sort of like, articulate what he really want to hear, during the last time. And we all know that this body is not ours, and we kind of like rent out it, and then we leave it, and we die, and then our consciousness also always changing, and it traverses to another life based on the last thought, supported by the habitual actions, thoughts, everything, speeches done in that particular life. So yeah, that's a good point that you brought up. You said that he wasn't ready to accept that Western version of that truth telling. This is where we're gonna now dig into. Let's talk a little bit about truth telling attitudes maintained by Eastern and Western perspectives, medical professionals. Now, in the West, what we understand is that truth telling is a kind of a bioethic for medical professionals, and we understand that it is not just to simply enable patients to make informed choices about what's going on and what's going to happen, like the time that they're gonna spend from now. Uh, it is also something that patients might be interested about the kind of medications and how things happen, how things work. Nowadays, people, once a doctor says something, if they are really conscious, they're gonna Google that and see, kind of interested. So these two aspects, though, on one side, the Western version, what I understand from Western version is that they think that because that they are really open about this truth telling thing, the patients can make their informed choices. At the same time, they can sort of Google and get to know what the medications are. So, but suddenly, you and my culture, Sri Lankan culture, perhaps you might not have spent a longer time in Sri Lanka. I spent like around 26 years of my time in Sri Lanka, and in some other cultures as well. They think this is kind of not a good thing because they understand it differently. I'm not saying this is better than that. They think, because I understand this from a research. In one research, they say uh, relatives of the patient, cancer patient, didn't like to let the patient know if the cancer is at the fourth stage. But they were comfortable if the GP is to say, oncologist is to say, if the cancer is at the stage one,
Mhm.
right? So there are some mixed feelings about it. At the same time, I heard some of the groups, religious groups, some old folks saying that, you know, doctors in one country and some other cultures, they are not sharing the true condition of the patient because they are backed by spiritual points, so that they are not making the patient uncomfortable, painful. So it looks like there are pros and cons on the both sides. But I see, there's a legal point. This is one thing, because doctors don't want to take that responsibility. There should be a disclaimer, in terms of this truth-telling attitude. On the other side, I understand this is more about accuracy and honesty. Now, if I reflect upon the mindfulness teachings, if I'm not saying this is better than the other one, but I'm trying to see some references about truth-telling attitude of Western perspective. If a patient gets to know that this is something happening to me and this is my destiny this way, he or she can prepare for the next. That's one thing. The second thing is, if something is under the control, if that particular patient can pay attention, if he can take care of himself, herself, depending on what the doctors are going to say to that patient, based on truth telling as perspective, uh, probably they can get over this issue as well. So there are sort of pros and cons. So I think your father spent quite amount of time in Sri Lanka. So I don't know how he saw this thing. Uh, Probably he didn't expect that answer that the doctor said. So how would you see this truth-telling attitude? Although this is a bioethic for clinical settings, how would you see this? What do you see this in both contexts, rather than saying Western is better than the Eastern, Eastern is better than the Western? Certainly.
Yeah, yeah, no, it's a very important discussion that always happens around bioethics in healthcare, and it's a very nuanced perspective that you have to have based on the case that you're looking at. Like I said, looking at patient-centered care and kind of framing your understanding of what might actually work for the patient and what is the most ethical way to tackle these issues to improve their healthcare outcomes, right? And that's the ultimate goal. So what can we do to improve their healthcare outcomes and not to cause more harm than good? So with that goal in mind, you can bring in the practices that resonate for that patient. So I think the contention lies in the fact that, you know, if patients don't have all the information, if you know, if information is withheld or they're deceived, then that could be looked at as a form of paternalism from the healthcare provider, saying, "Oh, listen, they know more than the patient, and the healthcare provider should be the one to make those decisions," right? Which is why Western medicine typically gravitates, and within the cancer context specifically, towards patient autonomy. And what does that mean? It's giving them all the information that they need to know to make the right decisions for themselves. So not withholding information. Also, there could be liability issues there. You want to give them everything bluntly and openly, and also let them make autonomous decisions about, you know, how to plan the next stages of their life. So this is a very valuable thing, and it's a good thing. I think when you look at Confucian Eastern perspective, you know, you shouldn't minimize those as well. So the counter argument is saying, well, it actually might be the family's best interest, and the family members might actually know what to do for the patient. And yes, we value the patient's perspective, but if the goal is to promote their health care, and if the goal is to promote their healthcare outcomes with this disease and the progression of this disease, then maybe the family members are the best people to speak with and give all the information to, and withhold that information from the patient. What that does is it actually gives the patient a better mindset sometimes. You know, with my dad, he actually refused and rejected some of the things that the doctors were saying. He said, "I don't want to talk to you, to some of the palliative doctors. Stop telling me this stuff. I don't want to hear this. Go away." He would very bluntly tell them to leave him alone when he was in the hospital. And I understood that this is a very cultural thing, because he didn't see the point in knowing that information. Whereas I, on the other hand, would, if I were in that position, would want to know everything, right? So it was very interesting to see how he rejected that right as he saw the doctors come in. "Please don't talk to me. Nobody talk to that guy. You know, he's just going to tell me a lot of negative things." And even though those things were actually happening in his body, even though those things were factually true, he did not want to know. And honestly, in this case, I actually thought that was a good thing. And I think this is a very, very important lesson. And the reason why this is an important lesson is because it really helped him push to the very end and fight to the very end. He was on his hospital bed in the house when we knew that his entire pelvic bone was compromised by cancer. We found him one morning with one leg off of the bed because he had pushed it with his cane. He wanted to walk, you know, even though it was physically impossible. We knew that it was impossible, but his mind was so strong up until the very end. And I don't think that's a bad thing. So deception is sometimes, you know, it's sometimes a powerful tool, because ultimately it optimized his healthcare outcomes, because mentally he was more resilient, and mentally he didn't have a defeatist attitude and saying, "Yeah, you know, I'm stage 4, but I'm going to try my best. And I don't need to know everything that's going on because I want to try my best." So I thought that was very interesting and very eye-opening. And I'm sad that he wasn't able to share that himself, because he would have a lot to share. But I'm just expressing some of my own observations and those attitudes that he had, where initially, you know, it was very eye-opening to me, because I had the perspective that he should know everything, and that he should accept what the doctors are saying, and accept that he needs to go to hospice because they would take good care of him there. But patient-centered care, I think he was actually an advocate without really knowing that he was an advocate. He was advocating for that for himself.
Looks like there are a lot of things that this industry can increase in terms of people this way, right? I mean, it is not just the language barrier and other things. There are many other aspects that they have to look into, so that people, will be, I mean, patients will be more comfortable with the medical care. They will not resist to the care, rather than embrace and accept what's going on, which is what we understand by vipassana, seeing things as they are. That's the Buddhist perspective.
Exactly.
Suddenly, do you have anything else to add to the conversation that we may have missed out on?
No, I think this was a really good conversation, and I just wanted to share that, my dad wanted to continue to volunteer in this field and to contribute to, cancer care, and after his retirement, he wanted to do a lot of work in this area, but obviously, since he got very ill and passed away, he wasn't able to fulfill those goals of his. I hope that I was able to share, some of his story, and I think it's a very important discussion to have, because we're all getting older, and all of our parents are getting older, and it's a really important thing to think about in advance. Sometimes we kind of react to things as they're happening, but to sort of understand that these are the types of barriers that may arise, as we move through healthcare. Right now, we might be fine, but we just don't know in the future what's going to happen, right? So it's good. It's not a pessimistic view. I think it's kind of just being realistic.
And then getting ready for reality.
Exactly, and then having that framework in mind, so that when whatever the situation is that you're dealing with, you kind of have an understanding of the types of issues you might run into.
Great. Yeah, that's true. Dhamma folks, today, pardon me?
Yeah, thank you for the platform, Bhante Chandama. I really appreciate the time. And
you're welcome. Yeah. Dhamma folks, today we've been talking about cancer care. Cancer care in terms of cultural competency. And cultural competency is such an important perspective, because it is not confined to medical perspective, because it is extended to service professionals. I mean, when they do any service to any kind of group, people from different ethnic groups would like to feel a connection, to the accuracy, to the harmony of their partnership. And particularly we've been talking about cultural competency in terms of cancer care, because Sarani Fernando was our guest today, and she joined from Vancouver, and she had a lot of experiences, because her father passed away on January 20th. Was a good gentleman, and she observed these changes and these needs, and how could the medical system be better developed, especially from someone who she knew for a long time in her life. So appreciate it for that. Sarani, thank you so much for joining with us today.
Thank you. Have a good night.
Have a good night. And Dhamma folks, today was day 30 of our Dhamma Pariyasana episode series. And stay tuned with another series shortly. Thank you. Have a good night. Have a good day.